thought I also introduce myself. Maybe it's not needed, but my name is Professor Ans van der Ploeg, and I'm from the Netherlands, from Rotterdam, Erasmus University. And as said, I'm already very long involved in Pompe's disease. And I work at the Erasmus Center for Lysosomal and Metabolic Diseases. That's the center that I chair, and there we work on children and adults, and we also do research, translational research. I'm very happy that we have a session today, and maybe the next slide. We have a quite challenging program. We have 6 presentations, and 2 of these presentations will be on respiration, and then we have 2 that will be on nutrition and exercise. Then we will have a presentation on speech pathology and a presentation on pain. And I'm very happy that everybody is already here behind the table. And I would like to start to introduce the first speaker. That is Dr. Grazia Crescimanno. And she is a physiotherapist from Palmero, Italy. That's an island of Spain. Of Italy, sorry. Sorry. Now, I'm doing well. I tried to see whether you were awake, and you are. Thank you. So, and she started to be a physiotherapist and being very involved in she's a pneumologist. Okay, a pneumologist. So, thank you. She's a pneumologist and very much involved in respiration and in polysomnography, ventilation, and she will give her speech online. So, Matt, if you could start.
Good morning to everyone. Thank you for inviting me. It is a pleasure to be here today. My name is Grazia Crescimanno, and my talk will be about respiratory management of Pompe disease. As you know, Pompe disease is metabolic myopathy caused by a deficiency of the alpha-glucosidase enzyme, which is involved in the breakdown of glycogen. The GAA deficiency leads to glycogen accumulation in lysosomes in many tissues, and particularly skeletal, respiratory, and cardiac muscle in the infantile form. Diaphragm is the most affected respiratory muscle. Here you can see diaphragm histology, which shows ghost fibers. That are fibers that are inactive fibers and do not stand for myosin. You can see in the upper panel, and in the lower panel glycogen accumulation in form of PACE-positive granules. This is a magnetic resonance of the diaphragm. The diaphragm have an increased curvature which impair contraction. This is a specific pattern and is different from healthy control, but also is different in comparison to other neuromuscular disease. It's a specific pattern. Unfortunately, glycogen can also accumulate in upper airway or in lower airway. This tongue signal is a typical sign of Pompe disease due to fat replacement that manifests as a bright signal. You can see bright signal in 1, 2, 3, 4, and 6 patients. This is an endoscopic evaluation of airway because glycogen can accumulate in trachea, in bronchi, bronchioles, and cause tracheal or bronchial malacia and airway narrowing. This is not frequent but possible in patients, especially in patients who experience fast progression of respiratory impairment. And in the mouse model, glycogen can accumulate in distal cells alveoli and cause a complete cell disruption. In 2006, ERT was approved and it improved many aspects of the disease, prolonged survival, improved cardiomyopathy. However, in late-onset Pompe disease, it slows down the progression of respiratory disease, but after 3 or 4 or 5 years, patients can experience a progression of respiratory impairment. And so now important to monitor, to evaluate the respiratory function. And how can we evaluate? Okay, the simple test is spirometry. Spirometry measures mobilizable volumes. And in pump disease, it is very important to perform spirometry not only in sitting position as usual, but also in supine position, because there may be a great difference between sitting and supine, which is called postural drop, and this is a specific sign, so it's very important to perform it in supine position. This is an old paper that shows that almost all pump patients have postural drop, these children, adults, and that postural drop can increase over time. Unfortunately, there is the relation between respiratory volumes and respiratory strength is not straight, so it is possible to have normal volumes and reduced respiratory strength. For this reason, it's important to evaluate respiratory muscle strength. We have two tests. We have MIP, which is the maximum negative pressure that can be generated by forced inspiration. It is a volitional test. We have no time to go into details. However, it's important to stress that it requires careful standardization. And then we have sniff nasal pressure, or SNP, that reflects esophageal pressure, is easier to perform, and it is a good estimation of inspiratory effort. Why these tests are important? These tests are important because they can predict nocturnal hypoventilation. You can see that MIP less than 120 of the lower limit of normality has a good sensitivity and specificity to predict nocturnal hypoventilation. But what is nocturnal hypoventilation? It is the reduction of alveolar hypoventilation. If the ventilation is reduced, effective gas exchanges are reduced and CO2 can accumulate in the body. Unfortunately, symptoms of hypoventilation are not specific. Hypertopnia is specific, but may be unspecific. For example, the only symptom of nocturnal hypoventilation may be apprehension. However, we can record PCO2. We can perform transcutaneous capnographic recording of PCO2. You can see these abnormal peaks of PCO2 which occur during the night and possibly in REM stage, because in REM stage there is a physiological reduction of ventilation, and if this should be early addressed, because it can evolve into symptomatic daytime hypoventilation if not treated. And capnography and polysomnography, polysomnography plus capnography is the gold standard to evaluate nocturnal hypoventilation and abnormal respiratory events. So, nocturnal hypoventilation can be treated by NIV, but what is NIV? NIV is a form of life support It requires a facial interface, a circuit, a ventilator support device, and in most instances a heated humidifier. You can see we have different interfaces. We have a nasal mask or nasal mask, nasal pillows, cloth mask for people who are allergic to silicone, and mouthpiece, and different types of mouthpiece. Okay, and different circuits and different devices. Now we have a multifunction ventilator. The most important thing is personalization. The optimal method of NIV for each patient can be determined only by a careful assessment of patient's comfort, sleep quality, digital downloads, unintentional leaks, capnography, and secretion management. How does it work? It works creating a positive airway pressure, so air is forced into the lung and chest and lung expanded. But NIV also unlocks respiratory muscle, so it reduces dyspnea. In neuromuscular patients, low level of pressure may be used. No high density of NIV is necessary. And 24 hours of non-invasive ventilation are a safe alternative to tracheostomy. One important thing is after setting, don't forget it, because in the long management, abnormal respiratory events and asynchrony can occur, and residual hypoventilation or abnormal respiratory events can affect the prognosis, so the effectiveness of NIV must be checked. And we have different tools to monitor NIV. Now we can perform a remote control of NIV devices. And we also have some algorithms to solve some problems. For example, excessive leaks or abnormal respiratory events, or to improve patient's comfort. The success of NIV is defined by 4 items: good compliance, improved gas exchange, improved sleep and quality of life, and few side effects. And this goal have been achieved in late-onset Pompe disease because NIV improves ventilation, but it also improves quality of sleep and quality of life. We cannot forget that neuromuscular patients cannot cough, and this is the peak cough flow, a normal peak cough flow on the left and abnormal peak cough flow on the right. And this peak cough flow can be measured by peak flow meter, and we know that a peak cough flow less than 270 is associated with increased secretion retention and the risk of infection. But we have some manual or mechanical techniques to increase peak cough flow, and this is a mechanical device. This is the old mechanical device, and we have to thank Dr. Bach because he convinced Jack Emerson to remanufacture the coafflator, which was the original mechanical device. And in 1988 we had a new prototype of inexsufflator. And it is very important because mechanical assistance reduce morbidity and hospitalization. So, to summarize the management of respiratory complication in patients with Pompe disease, we can say we need new generation of ERT. NAV because it increases survival and improves sleep and quality of life. Mechanical cuff assistance because it increases survival and reduces hospitalization. Early antibiotic treatment in case of respiratory infections. And waiting for gene therapy. Thank you very much for your attention and bye.